that we use for the acetabulum. Sandeep.
Thank you, Alaric. Just to start off, I have no disclaimers, so I've got no financial gain from anything that I recommend or any slides that you see on this presentation. I need to thank two people for some slides I've borrowed. So what I was going to cover is type of osteotomies. This has partly been covered in one of the talks. A little bit about the pathophysiology of dysplasia. I'll talk a little about the Salter's osteotomy, the Degas osteotomy, and then briefly touch on PAO and shelf. Might spend a little more time on Salter's osteotomy because I had the pleasure of doing a fellowship there and working in the department when Bob Salter was still in the department. So how do we achieve this? Simple, three things you can do. Either you change the shallow acetabulum to a deep one, you redirect an existing acetabulum into a more functional position, or you cheat and you augment the edge of the acetabulum. So types of osteotomy, this is already covered, so I'll go through this quickly. You either can go reconstructive or salvage. Reconstructive, you've got to have redirectional or reshaping. Redirectional Salters, or you can use the PAO. And the reshaping is normally either Degas or Pemberton. That's a Degas and then a Pemberton. And salvage, shelf or a Chiari. I haven't done many Chiaris. So these slides never quite worked for me. Lots of lines on 2D images didn't really help me to learn how to do any of the procedures, so I'll leave them there. You've already been told a lot about the anatomy and the indications, so I only have to show you how to do them. Now, that's the difficult bit. I don't think there's any substitute for going and seeing these being done in, with your own eyes three-dimensionally. You can't really learn to do these procedures by listening to lectures or watching YouTube videos. So, a little bit on pathophysiology. Again, as previously defined, acetabular dysplasia is maldevelopment of the acetabulum. And we tend to teach our medical students that most of the development of the acetabulum comes from the triradiate cartilage. But you also have to remember that there is a growth plate at the lateral edge of the acetabulum. And obviously, you need a spherical head pressing congruently to allow the acetabulum to grow. So I want you to just look at this corner, okay, to see what's in that gap. That's a little bit about anatomy. So we put some dye in. You can see the joint line. You can see this gap, which is the cartilage at the lateral edge of the acetabulum. And then if you look at our anatomical picture here, there are two separate areas there. This little triangular black area is the labrum, and that's fibrocartilage. The rest of the blob that you see here is hyaline cartilage, and it's continuous with the triradiate. So this bit of cartilage here, which is hyaline cartilage, is the growth plate of the lateral edge of the acetabulum. Now, we've learned a lot more about the anatomy of this corner of the hip after we started doing ultrasounds. And now again, I'm going to say something controversial. We tend to tell our medical students that the cartilage is nourished by diffusion from the synovial fluid. But once we started doing ultrasounds of the hip, you can see when you're doing a live ultrasound, you see these multiple dots in the femoral head. And if you put your Dopplers on, that's flowing blood. So if we're telling people that there are no blood vessels in cartilage, how do we see these multiple dots of flowing blood? So now we've got slides which show that it is hyaline cartilage, and you can see these multiple dots which are blood-filled. These are sinusoids. So the original histology which said there were no vessels in cartilage is true, but there is blood flowing in the femoral head and the hyaline cartilage there. Okay? This unfortunate term limbus, was originally thought to be fibrocartilage. Actually, it is just the deformed lateral growth plate. So just to remind you of the anatomy there. I think it would be useful to think of acetabular dysplasia as possibly AVN of the lateral edge of the acetabulum. Okay, to jump ahead, two iconic slides. That's the hospital that I did my fellowship in. It was still called HSC when I was there. Things changed. It's now called Sick Kids, and they've rebranded themselves. When I was in the department, Salter was still active. He was in his 70s. He still came to Friday teaching, still gave the residents a hard time. Useful for the young surgeons in the audience, he did most of his work in his 30s. He had already written up his osteotomy when he was 33. Salter has calcification in 39, and then CPM when he was 46. This is original paper, great X-rays. Just one quick thought. In his paper there, he was a young surgeon, 2 years into his appointment, and he had already done 96 osteotomies. If you look at the population of Canada in 1961, Toronto was only 1.7 million. So there were only 38,000 live babies born, and he would have probably had only 38 cases in that area. So how did he get so many osteotomies to do? What I learned while I was there is that he did some missionary work in Newfoundland and Labrador, and he would actually hire charter flights to go to these areas, find these kids, bring them back to Toronto, treat them, and that's how he managed such large numbers in such a short time as a young consultant. Okay, just a reminder, Salters redirectional preserves volume, age 2 to 6. We expect to get an improvement as shown there. That's also a picture from his original paper. Setup, I use a bikini incision, plane between sartorius and TFL, find the lateral cutaneous nerve, split the apophysis, take the striated rectus off. I'd like to spend a couple of minutes here. These are the two things that I brought back from my fellowship. These retractors, which are the Rang retractors, and they help you to, the main technical issue is clearing the soft tissue in the sciatic notch and passing the jiggly saw tool. So these lock in each other, and when you pass them on either side, you can easily get the jiggly saw through. And these particular periosteums, which are sharp, flat at one end, and nice and smooth to help you clear the sciatic notch. So there we are, the retractor is in place, the jiggly wire will go through, you complete your osteotomy, put your leg into a figure of 4, try and get anterolateral cover, don't let the medial hinge open, and then fix it with either thread wires, and now more recently we tend to fix them with 3.5 screws. The AGAS is, again, reshaping, volume reducing. It's my choice for cerebral palsy kids, always done with a femoral osteotomy. I'll show you an example I did 2 weeks ago. So a similar approach to what I do for the Salters, isolate the nerve, get the apophysis exposed, split only the outer cortex. I only take 1 centimeter off the inner cortex. Guide wire in to show me my direction. Osteoderms, bring it across, use the graft from the femur, and I split the graft into 2 pieces so you get 2 triangles to pack in. And that was what we achieved. Did unilateral surgery for other reasons. PAO, I have no particular experience. I have a colleague in my department who does this for me, so I'm lucky in that respect. This is what you're trying to achieve. That's him operating. I borrowed his slides. And shelf is salvage. Late presenting DDH, ended up with this problem at 11. We put some grafts on the lateral edge. We sutured it to the capsule and then waited for it to mature. So that's what I said I would cover in 10 minutes. Types of osteotomies. My take-home message to you is the limbus, an unfortunate term which most people refer to as overgrown fibrocartilage, is actually only a tiny proportion of that is fibrocartilage. The rest is hyaline cartilage. It has sinusoids supplying blood flow into it. And this is things that we've seen only since we've started doing ultrasounds of the hip. It was known in the German literature for a long time, just that in the English literature, it hasn't been emphasized. And we still teach medical students that cartilage is supplied by diffusion from the synovial fluid. I think we now have enough evidence from live ultrasounds to show that there is blood flowing in the femoral head. And for surgeons who are operating, if you accidentally doing an arthrotomy ever nick the femoral head, you do get a drop of blood coming out of it. Okay? That's all. Thank you very much.